Good evening, everyone. Happy New Year, and welcome to the Winter 2023 Next Generation Medicine webinar. Tonight, we are presenting Dr. Irl Hirsch from the University of Washington to discuss the topic of diabetes types 1 and 2, what you need to know. My name is John Slote. I serve as Senior Advisor to President Dane McCullough at Gonzaga University, and I'm the Executive Director of the University of Washington Gonzaga University Health Partnership. In 2016, the University of Washington School of Medicine and Gonzaga University formed a partnership to help address the need for health professionals in our region and to help transform medical education, research, and innovation with the goal of improving regional health and prosperity. Together, the University of Washington School of Medicine and Gonzaga University are deeply committed to growing the next generation of healthcare professionals while seeking new ways to serve patients and help our region thrive. A significant step forward in helping us achieve these goals was the construction of our new Center for Health Sciences and Medical Education, Research, and Healthcare Innovation. We opened this past summer, and we're proud to welcome 120 first and second year UW School of Medicine students, 225 undergraduate human physiology students from Gonzaga University, and more than 300 students in nursing and undergraduate health sciences who will also take classes in the building. This dream was made possible with our partner McKinstry, who was key to this endeavor, as well as support from the state of Washington and our broader community. Once again, I'd like to thank you all for joining us this evening for this important conversation, and I'll turn the podium over to Dr. Darryl Podick to say a few words and introduce our presenter and panelists.
Thanks, John. And once again, welcome everybody. We're so glad you're here today, giving up part of your evening to learn about this important topic. I'm Darryl Podick. I am the Chief of Medical Education for the University of Washington Gonzaga University Health Partnership, and I'm also the Associate Dean for the University of Washington School of Medicine here in Eastern Washington. Before we get started, I'd like to thank our sponsors for tonight. These include Providence Healthcare, MultiCare Health Systems, Spokane County Regional Health District, the Spokane County Medical Society, the University of Washington Population Health Initiative, as well as the Inland Northwest Behavioral Health Organization. I'd like to let you know what you're in for tonight, in addition to a wonderful presentation, but let me tell you a little bit about the flow. Dr. Hirsch will present for about 50 minutes, and then we'll be followed by two experts locally, Anneke van Sloten and Dr. Carol Wysham, both of whom are practicing in the field of diabetes here in Spokane. They'll add their comments, and then we'll have a question and answer period. Please note that your question and answer tab is at the bottom of your screen, and feel free to submit questions. We may not get to all of them, but we'll try and lump them together and get to as many as we can. The other thing to know about today's presentation is that it will be recorded and will subsequently be available for all participants who registered this evening. We're very pleased, as John said, to bring you Dr. Irl Hirsch from the University of Washington. Dr. Hirsch is an expert on diabetes, and I think we're really in the midst of an epidemic of diabetes. God knows we don't need any more epidemics, but some of the figures that we have right now are more than 582 people, or almost 10% of the adult population in Washington State have been diagnosed with diabetes. There's another 160,000 who have it but don't yet know it. Every year, an estimated 45,000 people in Washington are diagnosed with diabetes, and every diagnosed case of diabetes costs an estimated $6.7 billion in Washington every year. So with these figures, you can see why we asked Dr. Hirsch to come and talk to us tonight. And it's really a privilege to have him tonight. He's a national expert and very, very committed to this. He's dedicated his career to patient care, clinical research, and teaching. And his focus in these areas has been in the treatment and management of diabetes mellitus. He is a professor and chair of the Diabetes Treatment Center at the University of Washington in Seattle. He's been there for over 30 years. He received his medical degree from the University of Missouri School of Medicine and then did his postgraduate training and fellowship in Florida. He then completed a research fellowship at Washington University in St. Louis. Dr. Hirsch has authored more than 200 papers, including a review of insulin in the New England Journal of Medicine. He's written over 60 editorials, 3 commentaries for the Journal of the American Medical Association, and numerous book chapters for both patients and physicians alike. In addition, Dr. Hirsch has been an outspoken proponent of appropriate pricing for insulin here in the US. Dr. Hirsch has served as the former chair of the Professional Practice Committee for the American Diabetes Association and has served as editor-in-chief for 2 American Diabetes Association journals. He's also served as a member of the American Board of Internal Medicine. And from both a research and teaching point of view, Dr. Hirsch has spent his career studying the best strategies for the management and use of better technologies for type 1 and type 2 diabetes. Without further ado, please join me in welcoming Dr. Irl Hirsch for our program tonight. Dr. Hirsch.
Great. Thank you very much for that very kind introduction. I am going to start by sharing my screen and hoping there are no technical glitches with this, and hopefully everybody can see this. And I will try to stay on time. It was a big ask to try to cover everything going on because one almost can't open up a newspaper or turn on the news without seeing something going on in the world of diabetes as we now enter 2023. Now, when I was putting this together and I realized that not everybody in the audience may know all of the common terms and blood tests that we use in the world of diabetes. So what I thought I would do to start off is just to make sure everybody understands this very simple blood test, hemoglobin A1C. And it's really interesting because I had a quick dinner coming home. I'm at my home right now in Bellevue, Washington, and the TV was on in the background. And I heard a commercial about one of the drugs saying how this medication will lower your A1C. But despite the fact that this is on prime time and on the 5 o'clock news, I want to make sure everybody understands that glucose, or the sugar in the blood, binds to these red blood cells, which is hemoglobin. In most people, this lives about 90 days. But what we have learned in our research, not everybody does it live 90 days. Glucose then binds to the hemoglobin, and it binds to it very easily. And this is all hemoglobin A1C is. It's glucose and hemoglobin. And by knowing this hemoglobin A1C, you have a direct measurement of your blood glucose control over the last 90 days. Now, this is an old diabetes control card, but it gives a general viewpoint of, I think, back in the 90s when this came out, what we thought was good control in the yellow, action suggested in the red, some very, very high numbers for A1C, and what this means in the middle panel for mean blood glucose. And as it turns out, these numbers aren't exactly right. And maybe more importantly, what we've learned with our research here in Seattle is that these numbers are different for different people. So if you may have an A1C of 8 with an average glucose of 180, somebody else could have an A1C of 7 also with an average of 180. And we've learned this over the last few years. And what it has done is it had, in my view, it's made A1C less than the perfect outcome for the way we look at diabetes control, or for that matter, how we diagnose diabetes. And that's what I think it's important to know. And understanding diagnosis of diabetes, I want you to understand before we go through these numbers that these are not arbitrary numbers for hemoglobin A1C or blood glucose. This is where, in a population of people, one would start to see a complication of diabetes that is only seen in diabetes, and that is diabetic retinopathy. And these are the numbers. So despite what I said about these limitations of A1C, you can see on the right that you have diabetes if the A1C is equal to or above 6.5. Prediabetes is this zone between 5.7 and 6.4, and it's a continuum. So if you're at 6.3, you're closer to diabetes than if you're 5.8, but you still have prediabetes, which means you are at risk of moving on to get diabetes. By the same token, look at fasting plasma glucose. Now, I underline plasma because these are not the finger stick capillary glucose levels you can buy at the pharmacy. This has to come from the lab. It has to come from the arm. Notice that prediabetes is this range between 100 and 125. Diabetes is equal to or greater than 126. Seems like that's sort of a strange number, but it really isn't, because in Europe, where they use millimolar, it comes up to exactly 7 millimolar, 7.0. Also note the 2-hour plasma glucose during a 75-gram oral glucose tolerance test. Interestingly, we don't do these much in the US compared to Europe and other parts of the world. I actually do them in patients where I'm trying to get an answer, is this diabetes or prediabetes? Notice again, you have the continuum for prediabetes, 140 to 199. If this test is over 200, it is diabetes. And then a random plasma glucose over 200, especially if there is classic symptoms of high blood sugar, hyperglycemia, frequent urination, thirst, and weight loss. That makes a diagnosis of diabetes. But like everything, there are caveats, because for all three of these tests, the risk is continuous, extending below the lower limit of the range and becoming disproportionately greater at the higher end of the range. So one is at a greater risk of getting diabetes if their fasting plasma glucose is 120, or one is more at a risk of getting prediabetes if their fasting plasma glucose is 99. But that's where the lines were drawn. And here's the other really important point that a lot of physicians don't know. In fact, I was talking to a cardiologist the other day, and he had forgotten this, and that is, in the absence of unequivocal hyperglycemia, a very high A1C, frequent symptoms of urination and thirst, for the diagnosis, one requires 2 abnormal tests from the same sample or in 2 separate samples. So if you have a fasting glucose of 135 and an A1C of 6.6, you have diabetes if it's from the same sample, because you have 2 tests. But what happens if the fasting glucose is 120 and the A1C is 6.7, where you have one test that says diabetes and the other test that says you have prediabetes? In that situation, you do not meet the criteria for diabetes. I wanted to spend some time on this because I know there are a lot of people in the community who wonder, do I really have diabetes or not? Now, once you have a diagnosis of diabetes, that says nothing about what type of diabetes you have. And so the classifications, it seems simple, type 1 or type 2, but it's actually not as simple as one may think. We usually start with type 1 diabetes because classically, this is what we would see in children. But we now know that 50% of people with type 1 diabetes actually present in adulthood. And this has changed, certainly in my career and Dr. Wysham's career. The oldest person I have seen in my career present with type 1 diabetes was 92 years old. So it can occur at any age. Autoimmune just means the body attacking itself. The beta cells are the cells in the pancreas, specifically in the islet, that make insulin. The body is attacking the body's own ability to make insulin. This usually leads to absolute insulin deficiency in type 1 diabetes. And there's another term I want to introduce called latent autoimmune diabetes of adulthood, called LADA. It's a term that a lot of people don't like using, but according to the American Diabetes Association, it's okay to use this term because the people in the room or reading the chart note knows what you're talking about. This is type 1 diabetes that occurs in adults, and it's important because usually when it occurs in adults, this autoimmune attack on the cells that make insulin is not as robust. In fact, in research that we have done here in Seattle, we have shown that diagnosing type 1 diabetes after the age of 18, 40 years later, a little bit of insulin is still made. And as a rule of thumb, that is not true in childhood onset type 1 diabetes. So it's a little bit different when it's with the adults. one can get these autoantibodies to show that is autoimmune. And as a rule of thumb, especially with childhood onset, insulin is required for survival. We are now 102 years since the discovery of insulin. Type 2 diabetes, which is most of the diabetes in the United States, we still see a loss of insulin secretion from the beta cell, but it generally never gets to zero. And on top of that, we see resistance to insulin. So the amount of insulin that is needed to bring the glucose level down, one needs more because the muscle and the liver is resistant to the insulin. Now, that's type 1 and type 2, but what we have become very interested in is all of the other types of diabetes. We become very interested in types of diabetes where there is one gene mutation causing the diabetes. And this is particularly true in families where there is a high prevalence of diabetes. If 50% of the people in the family have diabetes, it's a good chance it's not type 1 or type 2. Neonatal diabetes is something that we have seen a few times here in the last few years in Seattle. And it's a wonderful diagnosis to make because these people are diagnosed usually as type 1, and they don't need insulin. They can take a generic drug called a sulfonylurea. And it's really a life-changing event, especially in the room when all of us are in there and we go through the data to show what happens when the patient comes off of insulin. I've had 2 of those experiences in my career, and there's usually not a dry eye in the room, but one has to have a very strong indication that that is what is going on, and then one has to do the genetic testing. Diseases of the pancreas, we see this a lot in our clinic, people with pancreatitis, people who have had their pancreas removed for any reason. The most common drug-induced diabetes we see is from steroids, prednisone in particular, whether it's for asthma, rheumatoid arthritis, used as part of a chemotherapy. We see that a lot. But there are other types, gestational diabetes, very common, which occurs during pregnancy. We abbreviate that GDM for gestational diabetes mellitus. It's usually diagnosed in the 2nd or 3rd trimester of a pregnancy. And these are people that did not have diabetes prior to the pregnancy. And this is the one time where everybody agrees a glucose tolerance test should be done, usually in the middle of the pregnancy. And these women generally have a high risk of diabetes within the next 5 years. And then what my real interest is from a research point of view are types of diabetes that have not yet, we don't really know what the genetic mutation is. And it does not fall into any of the known genetic etiologies of diabetes. There are 3 general groups that we have where we generally know the genetic mutation causing the diabetes, but there are people we see and we scratch our heads and we don't know what they have. And we are now actually doing an NIH-funded study where we are looking for these people who don't have type 1 or type 2 or any of the other known types of diabetes. And this is called the RADIANT study. I can't see with everything on my screen the website, but it's there. And in fact, if you just Google RADIANT diabetes study, you will get to this page. You can read about the study and see if you might be somebody who would be a candidate or somebody in your family. And you fill out the form online. And if you go through adjudication, and indeed we can't figure out what kind of diabetes you have with a blood test and filling out the forms, then you get to come to Seattle. And we get to do more testing on you to figure it out. And I will say the other really interesting part about this is we are learning about all of these genes that cause these rare forms of diabetes. But as part of the trial, you have your entire genome looked at. And you get to talk to a geneticist and go through all of the things that may be found or not found. It's sort of like 23andMe on steroids, if that sort of interests you. But that's all part of the study, and there's obviously no charge. In fact, this is all paid for by our own tax dollars. Now, if we look at the number of people around the world with diabetes, and if we look at this going out to 2025, the International Diabetes Federation puts the world into 8 different areas, 8 different regions. And you can see it is estimated that in North America, we expect a 24% increase in diabetes, but actually that's not as bad as Africa, where that number is 134%, or in the Middle East and North Africa, that number is an 87% increase in diabetes. So this is really becoming a global problem. We are looking at it here in just in the United States and in our cities, where in some cities we are approaching 20% of the population with diabetes. But globally, as bad as this looks here in the US, globally, it actually looks worse. Let's look at the US statistics from the CDC. It's 11.3% of the US population. Actually, here in Washington State, we're a little bit below this. But if you go to some cities, like in New York City, they're approaching 20% of the population with diabetes. Diagnosed, it is 28.5 million adults. That is a lot of people. But the bigger concern, in my view, is that 23% of adults have diabetes and don't know it. And that's the reason why we just shake our head when someone comes in and they already have eye disease or nerve disease or kidney disease from diabetes. And by the time they have these complications, a lot of the things they could have done to prevent that, it's unfortunately too late. If we look at the numbers for prediabetes, 96 million people aged 18 years or above have prediabetes. Now that's 38% of all of us. 38% of the US population has prediabetes. Now, the good news about this is that for most people, it's something that really could be helped and could be treated with just lifestyle. The University of Washington and my colleagues, Stephen Kahn and Will Fujimoto, they actually published a study over 20 years ago showing that with intense diet and exercise, one could reduce the risk of moving on to type 2 diabetes by prediabetes by 59%. So it is possible. And if we look at the elder, I don't want to say elderly because I have a big birthday coming up, but if we look at people age 65 years or older, almost half of the population has prediabetes. And many of these people obviously will cross over into the diabetes bucket. Now, the CDC has these have several different systems and that they use to go and look at how much diabetes is used around the country, and they can do this at a county level, looking at both diabetes and obesity from the years 2004 and 2009. I want you to notice on the right side of the screen, if it's white, that means you are in the lowest quartile of both diabetes and obesity. If it's this blue color in the top left, you have the highest quartile of obesity, but not of diabetes. On the other hand, if you're in this almost maroon color in the far right, you're in the highest quartile of diabetes and obesity, both. This is what every county in the United States looked like in 2004. And I can see Spokane County over here on the right side of Washington State. I don't think you can see my pointer. I see King County. And if you just look for a moment at Spokane County, what you see is that light maroon color. So there is quite a bit of diabetes and a little bit of obesity, whereas King County had more diabetes than obesity back in 2004. This is 2009, where everything is getting darker, especially the southwest corner of the United States, the diabetes belt. This is 2014. Again, look at Spokane County and King County. We're getting more and more purple. And here we are in 2019. And again, I look at the southwest part or the southeast part of the United States. I look at Maine. I look at King County. I look at Spokane County. I look at parts of Southern California, and I just shake my head because this is what's happened. And there are many reasons for this, but the number one reason for this, and the map that looks very similar to this, obviously, as you can see, is it's the obesity. The obesity is driving this. Now, I went back to my slides and looked at a slide that I showed to medical students in the early 1990s. I think, in fact, Dr. Wysham's children saw this slide from me because things have really changed. We already noted, for example, in type 1 diabetes, it usually presents in children and young adults before the age of 30. That's not true anymore. We have to be on the lookout for it at any age. Type 2 diabetes presents only in adults above the age of 30. We just had the announcement from the CDC about this epidemic we are having in adolescents with type 2 diabetes. Type 1 people are usually thin, type 2 are obese. Not true anymore. We are seeing more than enough obesity, as I will show you in type 1 diabetes. Type 1 is due to autoimmunity, as I mentioned, due to pancreatic beta cells, which could be measured by autoantibodies. That hasn't changed. And type 2 diabetes with beta cell deficiency and insulin resistance, that hasn't changed either. Type 1 people need insulin, type 2s do not. Very important. Most people with type 1 do not have a family history. About half with type 2 do have a family history. And as far as identical twins are concerned, it's 35 to 50% in type 1s, depending on the study. But look at this with type 2 diabetes. It's over 90% of identical twins. Ketoacidosis. This is what happens when insulin is not available. This is how people with diabetes used to die before insulin. Very common in type 1, rare in type 2. We are now seeing more ketoacidosis, as I'll mention in a moment. And then in type 1, we see all of these other immune problems: thyroid disease, celiac disease, Addison's disease, vitiligo. They come in a package. Whereas the package with type 2, it's a different package, but it's still a package. Hypertension, high fats, specifically triglycerides, low good cholesterol, high uric acid, and something on the back of the neck, usually called acanthosis. It looks like a dirty neck, but it's just hyperpigmentation of the skin, and it looks very dark. So here we are in 2023. Things have changed since I taught Dr. Wysham's children. The age, we're seeing, as I said, an explosion of type 2 in adolescence. 50% of type 1s are now diagnosed in adulthood, not what we saw years ago. Body mass index, this is the metric we use to look at obesity. 1/3 of type 1s are overweight, 1/3 of type 1s are obese, and this is the same as the general population. No difference in the body weight now of type 1 diabetes than it is with the general population. The reasons for this are complex. The most important reason is we don't see these really, really high A1Cs like we used to, where you're losing all the sugar in the urine. We see more ketoacidosis now in type 2s than we did in the past, especially in African Americans in particular. And it's rare, but we see more of it than we used to, especially with people coming into the hospital with this class of drugs called SGLT2 inhibitors, advertised on TV, Jardiance, Farxiga. And you can get more ketoacidosis with these drugs, more so of concern in type 1 diabetes than type 2. But we do see this, and especially we see this when patients are sick in the hospital. So childhood and adolescent type 1 diabetes projection for the future. What do we know? Well, let's look at this from the different places in the world. On the left, you see the orange line, which is Africa. You see the green line, which is Asia. We are seeing this projected increase over the next 25 to 30 years in these countries. Whereas if we look at North America, it's going up, but it's not going up as much. Now, I will say that right now in the United States, we are at a 2% per year increase in new diagnosis of type 1 diabetes. So the numbers are going up, but not as much as in Africa and Asia. And if we then go ahead and look at countries based on income, what you see is that the lower middle income countries and the low income countries have this greatest increase in type 1 diabetes. And the question is, well, why is this? And there's a lot of possible reasons. The diet of the mom during pregnancy, how the baby is delivered, infant feeding, childhood diet, microbial exposure. What has gained a lot of attention is the hygiene hypothesis. We are a much more sterile community now than we were 100 or 200 years ago. And so when you are exposed to a new virus, for example, and your body has never seen that before, because we are spending so much time being sterile, is the body able to mount a response to that virus, or does that actually initiate autoimmunity? And that is the hygiene hypothesis. None of these are proven for sure. The use of any antimicrobials in early childhood has been a speculation at that. Now, interestingly, living closer to the sea seems to be an increase in risk. I don't know why that would be, but that's been shown over and over. And there are a variety of different chemicals. I won't go through all of these, but these chemicals have also been implicated, but none of them have really been proven. The gut microbiome, and this is really interesting because we know in type 1 and for that matter, type 2 diabetes with newly diagnosed patients, their microbiome is different. This is the bacteria in the gut. And the question is, what is the chicken and what is the egg? Are these different bacteria causing the diabetes, or is the diabetes causing this change in the gut microbiome? And the real answer is we don't know. So understanding this relationship between blood sugar control and complications. When I came to Seattle 33 years ago, one of the reasons I came here was to be involved in this study, which was actually published in 1993, called the DCCT, or Diabetes Control and Complications Trial. Now, this happened to be a study in type 1 diabetes. A similar study was reported in 1997 for type 2 diabetes, but they both showed the same thing, and that is the higher the A1C, the greater your risk for any of these complications of diabetes. These are small vessel complications. Retinopathy is eye, nephropathy is kidney, neuropathy is the nerve, and microalbumin in red is the small amount of albumin that occurs the first sign of diabetic kidney disease. The point is this was our first proof that glucose control made a difference. And it was really a landmark study. We may never see anything like this again, at least in my lifetime, because until then, huge controversy. We didn't know, but we couldn't answer the question because we didn't have the tools to answer the questions until the 1980s. That's when things really changed. Going back even further, in 1923, 100 years ago, the Nobel Prize was awarded to Banting and MacLeod in Toronto. The insulin was very crude by today's standards. And if anybody has the chance to read the book, The Discovery of Insulin by Michael Bliss, it is well worth reading all of the real chaos that occurred around the discovery and the controversies and the infighting, making the infighting we are seeing in our politics today almost minimal compared to this. This was really, really bad what happened, and a lot of it was covered up for many years. So we've come a long way when we look at insulins right now. These are the insulins. We started with one insulin in the 1920s. This isn't even all of them. This is just an example of the insulins we have to work with today. This is just the insulins we have, a more complete list of all the insulins in 2023. And in my career and in Dr. Wysham's career, this has just been an explosion of insulins, which has, for the most part, been a wonderful thing for patients, for those who have access to it. And this is the whole issue. 1 in 4 Americans up until now have had to ration their insulin. And so we have all these insulins. And I should point out, from a global point of view, there are still many parts of the world that have minimal access to any insulin, especially when you get into the low-income countries. So we are actually very fortunate here in the United States. Now, if we look at insulins here, the insulin analogs have continued evolution, despite concerns that that wouldn't happen due to the fact that the costs have gotten so high and now the costs are starting to come down. We do have new evolution with the insulins, which is good. The monitoring of capillary blood glucose, or continuous glucose monitoring in type 1 diabetes, it's now standard of care, at least in the United States. And the fact that we can look at glucose levels, even with the finger sticks, if it wasn't for that, the DCCT would not have been able to be done. And it's made the complications of diabetes such less of a problem as far as having the ability to treat the diabetes earlier. Because the one thing about type 1 diabetes compared to type 2, when the diagnosis is made, you know it. You're not walking around for a decade with high blood sugars and not knowing it. And the ability to look at the glucose levels, whether it's blood or through the continuous glucose monitor, has just revolutionized type 1 diabetes in my lifetime. The insulin pump therapy has evolved so that now the sensor can tell the pump how much insulin to give, at least in between the meals. The patient still has to press the button to tell the pump to give insulin with the meals. And this has always been the goal. I'm not going to show you everything that has happened with this, but this has also, just within the last 5 years, 3 years, has made type 1 diabetes therapy in our clinics completely different. And in fact, in our clinic right now, over 70% of our type 1 patients are doing this automated insulin delivery. The pump is great, but it's really the sensor with the pump, and even better than that, the sensor telling the pump how much insulin to give. And so, due to the improved glucose control, thanks to the DCCT, the dramatic reduction of microvascular complications, which we are now seeing, we are not seeing these anymore. And for those who have access to these new tools, and to the providers and healthcare systems who understand to use this new technology, we are seeing this dramatic reduction in the complications of diabetes. And it's very interesting to me when I talk to our endocrine fellows. These are physicians who are in training to be endocrinologists, and they come into our Diabetes Institute, and we just don't see the amount of this as they see in the low-income clinics, for example, at Harborview Medical Center, our big county hospital here in Seattle. We just don't see as much of it anymore because these are mostly people who have had access to the expertise and the technology and the medications for now 20 and 30 plus years. So here we are in 2023. Macrovascular disease is overall reduced, but one needs to understand the glucose control is only one of many reasons for this, because with macrovascular disease, heart disease and stroke, it's also cholesterol, which we're doing a better job with, blood pressure we're doing a better job with, and we're seeing less smoking, especially here in Washington State compared to other states. Now, there was a new drug that was just approved last month, teplizumab. It is for stage 2 type 1 diabetes with dysglycemia. Now, what does that mean? I'm going to show you the stages of diabetes, but stage 2 means blood sugars haven't gone up yet, and dysglycemia means blood sugars aren't normal, but they haven't reached the stage of diabetes. And so this means that if you have somebody that you are screening for type 1 diabetes with autoantibodies, and their blood sugars aren't yet in the diabetes range, we now have a drug that can prevent clinical diabetes or stage 3 type 1 diabetes for people above the age of 8 years. Now, this was literally just approved a few weeks ago, and how we're going to use this is still unclear to me. It's an immune modulator. That's all you really need to know. It modulates the immune system, which can delay the need of insulin. I have not shown, I was not involved in these studies, but it has been shown by an average of 2 years. And a lot of us think this is going to be the first of many different ways that if we can catch people before they develop type 1 diabetes, we can prevent it from progressing. At the top, you see the stages, pre-stage type 1, stage 2, and stage 3. On the left, you see the beta cell function. If one is going to get type 1 diabetes, they have to have a genetic predisposition. Then over time, they get autoantibodies. That is stage 1 if the autoantibodies are there, but the glucose is normal. It's stage 2 if the glucose levels are not normal, but they don't have diabetes. Once they get to stage 3, they have clinical type 1 diabetes. Teplizumab is for stage 2. There are many questions all of us have. Who will pay for these antibodies for potential patients? Who is the treating physician? I don't see patients with type 2, type 1 diabetes, stage 2 type 1 diabetes. The terminology is kind of interesting. I don't see these patients. They're generally cared for by pediatricians and family physicians. How will the insurance pay for this $193,000 price tag, not to mention the price of the 14-day infusions and the cost of the nursing and the physician time for the 14-day infusions? And then who's going to go fight with the insurance company? I mean, these are all the questions that I have, sort of practical questions now that we have the drug. But again, this will be the first of many therapies to delay the presentation of type 1 diabetes. And so from that point of view, it's a very exciting time. Now, the reality here in the United States, 1 in 4, as I mentioned, have to ration insulin due to costs. Now, starting January 1st, just 10 days ago, if you're a Medicare patient, your cost is capped at $35 a month for each insulin. If you're a commercial, if your insurance is commercial insurance, nothing has changed. And we can thank our Senate for that because that's what they voted for in August. Depending on the survey, there are between 5,000 and 7,000 people like Dr. Wysham and I, who are endocrinologists, realize that not all of us see people with diabetes, but there are 1.6 million people with type 1 diabetes. What that means, if you just look at the math, is that Dr. Wysham and I can't see all of these people, and people like us can't see all these people. This will have to be cared for in the primary care world. Now, what we know is that in adult type 1, not in children, half of Americans receive their care from primary care physicians, where I can tell you here at the University of Washington, type 1 instruction during training is usually minimal. Most of the instruction is with type 2 diabetes. And it's been shown in several trials that A1C levels are about 1% higher in the primary care physicians' clinics than those cared for in endocrinologists. I mean, it's not an editorial, it's just what the research has shown. The access to technology is also dependent on many factors, including the familiarity of the treating physician. I mean, one of the good things, if there can be a good thing about the pandemic, is both the physicians and the patients were at home and seeing all of the advertisements on TV for continuous glucose monitoring. And there was just an explosion of primary care physicians here in Seattle coming to me asking, how do I start patients on this? I'm seeing the commercials on TV. The patients are, we want it. And that actually was one of the silver linings, at least in the world of diabetes, from the pandemic. Now, if we look at type 1 diabetes who is using the technology, the bottom line is about half of type 1 patients are not using either a pump or a sensor, whereas we have 12% using a sensor without a pump and 29% using a pump and a CGM. In my view, the CGM is the most important part of the technology. According to this survey, it's under 50%, but we know this is growing every week and certainly every month as the payers are getting much better with covering the continuous glucose monitoring. Now let's talk about type 2 diabetes. As I mentioned, it's often present for years before diagnosis, and it can present with any complication. And there's nothing that I dislike more than somebody coming in with an infected neuropathic foot ulcer related to neuropathy from diabetes and they didn't know it. Or I can't even remember how many times I've had referrals from the ophthalmologist due to advanced diabetic eye disease and the patient didn't know they had diabetes. In fact, there was one I remember so well. The ophthalmologist referred the patient to me, and even the ophthalmologist didn't tell the patient that she had diabetes. I was the one who had to tell her, even though her eye disease was quite advanced. Now, we know that type 2 diabetes is more common in people who are obese and in every ethnic minority we see in the United States. As I've noted twice already, one needs to have both insulin resistant and insulin deficiency. Otherwise, everybody who is obese would get diabetes, and that's not the case. We are seeing this explosion of type 2 diabetes in adolescents and young adults. And work done by my colleague Stephen Kahn here in Seattle has shown that the lesion that results in beta cell deficiency, when it occurs in a teenager, it's more aggressive than what we see in adult type 2 diabetes. We don't know why that is, but the concern is 20, 30 years from now, these youngsters are really going to have a hard time given how more aggressive their diabetes is compared to their parents and grandparents. And globally, if we look at the IDF, you can see where the diabetes for the undiagnosed patients, you can see the countries, and actually for undiagnosed, the US is not doing as bad as other countries, but where the healthcare systems are not as sophisticated is where you see more of the undiagnosed diabetes. And if you look globally, almost 1 in 2 adults with diabetes are unaware they have diabetes. One of my colleagues, Stephanie Page, her research is in Africa, and she says all the time, they have it and they absolutely don't know it. And even if they did know it, there really wouldn't be much they could do about it. It's even worse for type 1, where they have a very difficult time getting insulin. And in type 2, as far as medications are concerned, they, for the most part, just have metformin. They may have a little bit of glyburide, but again, we have to consider ourselves so fortunate given that that problem, anyway, for our country as a whole does not exist. What about glycemic control in the US for type 2 diabetes? Well, this is recent data from the New England Journal of Medicine. And, we would like everybody to have their hemoglobin A1C or glycated hemoglobin below 7%. And what you see here in the blue line is that by 2015 to 2018, it's only 50.5%. But the concerning part about that is the number of people under 7% has gone down from 2007 to 2010. It was 57.4. It's now 50.5. 8% is also going down, meaning it's gone from 79% to 75%, meaning a quarter of the population is above 8% in the United States with type 2 diabetes. Again, from a national level, this is really a huge problem. And then for those people who are receiving insulin with type 2 diabetes and A1Cs under 7, and if we look at the different ethnic groups of the Mexican Americans, the non-Hispanic Blacks, and the non-Hispanic whites, nobody is doing well. But the Mexican Americans receiving insulin, they're down here in single digits of A1C less than 7%. It's just not good no matter how we look at this. Now, when we think about type 2 diabetes, how does one decide which therapy to pick? And I would say it's pretty easy, because what's easy but not emphasized enough is the whole concept of you are what you eat, and diet and exercise. We have patients who literally live by this rule and they do extremely well. But more often than not, what I see is somebody is diagnosed and they're given a prescription of metformin, and that's the end of it. But the diabetes educators, and whether it's in person, it's online, you have specific questions that only apply to you, and there is so much good information online from the respected sources. This is such a key part of diabetes. And to say, well, that's good to say, it can't be done. This is a patient I saw within the last week. He's now 51. He's had his diabetes for 4 years. When I originally saw him, it was right when he was diagnosed. His A1C was 8%, and he was actually put on insulin and metformin when he came into me. And he met with our nutritionist. He joined a very intensive gym, and this was before the pandemic. Then he did pretty much everything virtually. He's on a low-carb diet. He does this exercise pretty much every day. Eventually, we stopped his insulin. His A1C is now 5.5. He started at 8. And he does have diabetes, but this is his continuous glucose monitor. His blood sugars look virtually normal. And if you look at his time in range, it's almost 100%. That is between 70 and 180, with a glucose of 120 on average. Now, you would say, well, that's pre-diabetes, and it is, but he does have diabetes because he's still on metformin. But the point is, his blood sugars are extremely well controlled, and this has been his diet and exercise. Now, one of the problems many of my colleagues who I went to medical school with, is they can't keep track of all these medicines. It started with animal insulin. When I was a medical student in the very early 1980s, this is all we had as far as the insulin was concerned. The sulfonylureas, the drugs like glyburide and glipizide, these actually came into the US in the 1950s. 1982, we had our first human insulin. Metformin came to the US in 1995. It was actually available in Europe in the late 1950s. And then things got crazy. We had this huge increase of both insulins and type 2 diabetes drugs. And it's gotten even more crazy, to the point that here we are in 2022, the tirzepatide was approved. And this list is going to continue to grow. And this is why my colleagues from medical school can't keep up with it. Dr. Wysham and I, we live and breathe, we do the studies for these drugs, but unless you are doing this every day like we are, it's really tough to keep track of this. Now, how do these drugs work? Well, all of these things you see on the slide can lead to high blood sugar or hyperglycemia. And these drugs we talked about, the sulfonylureas coming from the 1950s, they work, they're very cheap, and they work by stimulating the beta cell in the pancreas to make insulin. Metformin, on the other hand, is a really interesting drug. It works on the resistance of the insulin, mostly in the liver. And then the SGLT2 inhibitors. These are advertised on TV. They work by having you lose glucose in your urine. So you're peeing out glucose, and they lower the glucose that way. And as we're talking about these SGLT2 inhibitors, I think the more important thing to know is they're much more important than lowering the blood sugar. What you need to know about this class of drugs that go by Jardiance, Farxiga, Invokana, and Steglatro, which we don't use very much, is they reduce the risk of major cardiac events by 10%. If somebody has known heart disease, they reduce cardiovascular death by 17%. If you have heart failure, it reduces hospitalization for that heart failure by over 30% with or without known heart disease. And it reduces cardiovascular death and heart failure hospitalization by 25 to 28% with and without diabetes. And this is the reason why these have become an extremely popular and important drug for the cardiologist treating heart failure, whether or not somebody has diabetes or not. Extremely important. But it gets more interesting because it also reduces the risk of dialysis or kidney transplantation by almost 40% in those with pre-existing kidney disease. And again, this is people with or without diabetes. So these drugs have just exploded in the cardiology and the nephrology world for the heart and the kidney. Now, one other important drug, the GLP-1 receptor agonists. These are advertised on TV too. Now, as opposed to the other drugs, these drugs work at several points. They work by keeping the food in the stomach longer and reducing gastric emptying. They work on the brain, and this may be the most important thing they do because that satiety switch that turns the brain on and off for food, it turns it off. It doesn't turn it off in everybody, but in most people, it does turn that off, which turns out to be very important. It works in the pancreas by turning on insulin when you need it and turning off another hormone called glucagon coming from the alpha cell in the pancreas. It turns that off, so that's all a good thing. And again, besides lowering the glucose, which these drugs do, it's more than lowering the glucose. And what you need to know about these drugs is there are a few of them. Their trade names, and I'm not allowed to say trade names when I talk to doctors, but to patients, I think it's a good thing to do because this is how you know these drugs. Byetta, Victoza, Bydureon. I can't believe we are already 13 years since Victoza came on the market. And now the most common ones we use are weekly drugs, Trulicity, Ozempic, and Mounjaro. And those drugs are used weekly. And as a group, when you look at all of the studies, they reduce major cardiac events, heart attack, need for bypass surgery, stent. They reduce all of the events by 14%. And early data strongly suggests a beneficial effect on kidney disease. We won't have that definitive data until next year, but it looks like we're going to get it. And we're very excited about that because it's yet another tool to treat kidney disease, both with and without diabetes. And then what's received so much attention recently is the tremendous weight loss seen with Victoza, Trulicity, and Ozempic. And these can be used for weight loss. So, for example, Victoza in its highest dose of 3 milligrams, it goes by the trade name Saxenda. That's indicated by the FDA for weight loss. And Ozempic, which is semaglutide, is the generic name. It has another name called Wegovy, which is the highest dose that is also used for weight loss, but not diabetes. Now, Mounjaro is the one that just came out. And to put this into perspective, they showed that with their highest dose of 15 milligrams, there is a 22% body weight loss after 1 year. 22%, more so than the other drugs. And the reason why that is so interesting to me, and it all works again by the brain, is that as a rule of thumb, if you look at bariatric surgery, you're looking at a 30% weight loss. This drug in its highest dose was 22%. That was the average. Some people were much more than that. And it again works on the brain. All of these drugs work on the brain. And it's been very interesting watching this with patients and watching their weight come down very quickly. And I'm sure there'll be questions about this because it's really been fascinating watching this evolve. Now, unfortunately, and this has received a lot of news, these drugs have become in short supply because so many people are taking this for weight loss, or they want to lose 10 pounds to get into their dress for the formal or for the wedding. It's become very popular in Hollywood. They can get the prescription from their doctor. And now we have this shortage of people with diabetes, or people with diabetes with heart disease in particular, where I would really want to use this drug. I'm hopeful that this shortage will end soon. But right now in Seattle, I know, at least as of last week, I don't know about this week, I know of one pharmacy, which I will not say, where they can get all of these drugs. Maybe it's better in Spokane, but this has been a huge problem. Now, some other facts about these GLP-1 receptor agonists. According to the American Diabetes Association, and I think most of the societies around the world, this should be the first injectable for blood sugar treatment before insulin. If the blood sugars are high and you need another drug before going on insulin, this should be what is given. The problem is it's extremely expensive, and not all of the insurance companies cover it well, although it's getting better as time goes on. If you go to goodrx.com, which I did the other day from my zip code here, if you pay cash, it's about $900 a month. And in fact, if you look at the data for who's getting metformin in orange and who's getting one of the GLP-1 receptor agonists in black, you can see it's very poorly used if you look at everybody with type 2 diabetes going to 2019. I think we do a little bit better than that now in our clinic, but it's always a fight, especially a few years ago. And again, I get back to race and ethnicity. And depending on which group you're looking at, we are seeing real concerns, in my view, about inequities. This group at the bottom actually are the Asian population, and the blacks are the ones just above them. But nevertheless, we again get into this whole issue of inclusion, diversity issues when it comes to diabetes. And my final comments about this topic is our complex system makes it difficult for many who could afford these drugs to use them. And while it is underused for heart disease prevention, I remain excited about its impact on kidney disease based on the data we've seen and what I see anecdotally in my clinic. And if we look at these people who have known with high cardiovascular risk, again, we see from this study a lot of metformin use, but very little use of the GLP-1 receptor agonists, pretty much in single digits. And in fact, there has been study after study after study looking at both the GLP-1s and the SGLT2 inhibitors in people with heart disease and kidney disease. And for the most part, the use of them in this country are in single digits. And the number one reason for that is that the payers look at these drugs as blood sugar drugs, whereas I look at these drugs as cardiovascular and renal drugs, but the payers are not there yet. So to summarize, the diagnosis of diabetes, and I can't read this because may be confusing, and in fact may be neither type 1 nor type 2 diabetes. And so think about that, especially if you and your doctor are confused. Diabetes has become a global epidemic, and in the US we are seeing more adolescents with type 2 diabetes, and we're seeing more adults with type 1 diabetes, not what I learned when I was a medical student. Undiagnosed diabetes remains a major global problem. The tools to treat type 1 diabetes have dramatically improved, yet our outcomes are not what they could be due to many reasons, including the cost of insulin. I mean, it's one thing if you can't get a sensor or a pump, but when you can't afford your insulin and you are intentionally withholding insulin so you can get to the next paycheck, that shouldn't happen in this country, and yet it does. Furthermore, diet and exercise can be extremely effective for type 2 diabetes treatment. And I want to emphasize, we don't emphasize enough diet and exercise and the importance in type 1 diabetes, in atypical diabetes. It doesn't matter. Pancreatic diabetes, it's always an issue. And I saw a patient yesterday who has not changed what he's eating at all. He is a physician with newly diagnosed type 1 diabetes, and his A1C is still 9%. So he's got all the technology. It doesn't matter if you don't pay attention to diet and exercise. Medications for type 2 diabetes have exploded in number. The SGLT2 inhibitors and GLP-1 receptor agonists can also result in cardiovascular and improved renal outcomes, all a very good thing. The GLP-1 receptor agonists are effective weight loss drugs, very important. And we struggle as a society getting all of the education, medication, and technology to all people living with diabetes. This is a fundamental problem. And it wasn't an accident that I put education first. You can't do this without having a really good, thorough understanding, both for yourself if you're the patient and your family members. You eat together as a family, you exercise usually as a family. You have to know all of this as a family. So I'd like to conclude that the classification of diabetes, its treatment, and its implementation will change nationally and globally over the next decade. That's why I'm so excited. What it will look like by then, for me, is difficult to predict. And with that, I hope I didn't go too far over my time. I thank you all very much for your attention, and I'd be happy to take questions.
Great. Thank you, Dr. Hirsch. That was just wonderful. I think putting the context there of, a really expanding disease, but also so much hope and so many new things that are exciting in the field. I think before we open up for questions, I'd like to direct a couple questions to our panelists here in Spokane. And I'm going to start with Anneke. And Anneke, against this background, what is the most exciting thing that you see or most gratifying thing that you see with the patients you see every day?
Yeah, great question. And thank you, Dr. Hirsch, for that great presentation. I think you did such a wonderful job of highlighting both, even in the last 5 years since I've been focusing on diabetes, really the amount of diversity in terms of the tools or therapies or technology we have to treat this disease, but as well as some of the barriers that we encounter in clinical practice, be it cost, be it scarcity of providers or technology, be it education. So I thank you for that. Yeah, and I think in answer to your question, really, CGMs have been the most exciting therapeutic option that I have seen utilized in my practice, both in terms of type 1 diabetes and being able to see how people are dosing their insulin and the timing and the pieces that go into that, but also the ability to put a CGM on somebody for 2 weeks and see how simple carbohydrates really affect their blood sugar numbers and then how high they rise, to really reinforce some of that lifestyle change and how important it can be and how much difference it can make before we have to add on medication therapy at that point. So the tool of the CGM, even for a short time, it has been such a wonderful, wonderful add.
Earl, how about you? What excites you about the field of diabetes now? You've been doing this for a long time and certainly our local expert. So what's your take on that?
Yeah, I'm going to age Dr. Hirsch. Tomorrow is Nick's 40th birthday. So I know you knew him as a first or second or third year medical student. I am a couple of things I want to emphasize is the issue related to weight maintenance in patients with especially type 2, but also patients with type 1 diabetes, given the statistics, is reaching a new level of importance. And the new ADA guidelines really identify that patient who has a significant weight problem, which not only is contributing to diabetes, but contributing to so many other problems. We are really emphasizing weight as an important measure in addition to A1C. So applying the medications that Dr. Hirsch talked about that have the weight benefit is now rising to the occasion that we as practitioners can hopefully provide those patients who need weight management these medications at an earlier stage. Obviously things are in transition. It's going to take a while, but I'm very, very excited about that. I share Anneke's enthusiasm about CGM and how it's used, and think everyone can benefit from at least a short-term exposure to seeing what lifestyle does. But I do want to just push back a little bit to one of the things that Earl said very respectively. I totally agree that lifestyle is important, but I also recognize that patients who have longstanding diabetes, lifestyle cannot cure diabetes. And I do not want people to leave this seminar thinking that, oh my gosh, if I was just better at doing diet and exercise, my diabetes could be cured. Once you lose enough insulin secretion, you can't cure diabetes, but it can certainly help you manage it more effectively and make you more healthy in the long run.
All right. Well, thank you.
I mean, I don't disagree with that at all. I think what happens with residents when they come out of their residency program and go into practice is they are so focused on the medications, and they are like that for 20 and 30 years. And the whole topic of lifestyle is never even it's not even on their radar. And we see that both in type 1 and type 2 diabetes. And I think that is really the most interesting thing to me. I see it, and I don't know this only from my patients who come in and tell me. I have so many physicians over the years who are also my patients, and they're the ones who really focus on that. Since I just didn't know, and I agree with Anneke. The whole issue of watching the blood sugar, whether you have type 1 diabetes, type 2 diabetes, or pre-diabetes, you learn so much about what different types of food do, what different types of exercise do. And one other thing I should point out is the way one person responds to food may not be for that same food how somebody else responds to that food. And that's really important. And where it even gets more interesting is how that food responds around the time of physical activity. And it's very complex, the physiology, what's happening. But I think importantly, people figure out how food and exercise, how it affects their blood sugar. But the one thing that we have not figured out how to do in type 2 diabetes is how to stop that beta cell from lowering the amount of insulin it makes over time. We don't know how to do that yet.
Let me just ask a question that's related to that, and Carol, particularly since you mentioned the focus on body weight. I was recently in a discussion regarding an anti-obesity bias that, a lot of people feel like we're very biased of folks who are overweight. And how do you address the weight issue in many of your patients? And I'll give Carol, since you brought it up, I'll let you go first, and then we'll go from there.
So my approach to dealing with patients with diabetes is to recognize the dual contribution of genetics and lifestyle, and to really emphasize that for the most part, we have a huge genetic potential for obesity, and lifestyle can make a difference, and it's not going to work for everyone, but that anything that they do with lifestyle is going to make themselves healthier. And so I try to disassociate weight with health and make sure that people understand that all the things we're talking about to control their diabetes and control their weight is going to be helpful. No question in my mind that a huge percentage of the healthcare professionals assume that if you're overweight, you're lazy and you have no willpower. They just don't get the latest science to show that it's not just your brain and willpower, but there's hardwired physiologic changes happening in the brain that make it hard for them to lose weight. So, I totally agree that it's important. We talk about it every visit. I monitor weight over time. I have lots of patients who've lost 60 pounds over a 10-year period of time with no medications that are helping them with their weight. I think that it is key for health and separating it necessarily from weight, that lifestyle be discussed with patients every time they come in.
Great, thank you. Anneke, or Earl?
Anneke, do you want to go first?
Sure. I mean, I can jump in. Yeah, I think it's such a great question, because I feel like there is a lot of shame messaging that goes into that. So how do you continue to have this conversation about health and focused on health and well-being while trying to avoid this sort of cycle of shame that really is not motivating and not helpful? So I think Carol's point about talking about some of the neurotransmitters in the brain and then kind of tying that back to that GLP-1 class and how that hits that in terms of satiety really helps to take some of that shame messaging away and also sort of reinforce some of that. And as a result, you are able to eat smaller portion sizes. So what would that look like for you? Or, sort of identifying some smaller goals that are meaningful to the patient in that too.
I happened to see, and the TV was on, and I happened to see, and I don't know if anybody on the panel saw 60 Minutes last Sunday. And there was this wonderful piece on obesity, and a physician, I believe she was in New York with her patients. And I felt like I was talking to the scientists I work with here at the University of Washington. A lot of the understanding on how the brain works in terms of obesity signaling and the various signals actually happened here in Seattle over the last 25 years. And if you haven't seen this piece last Sunday on obesity, you should, because it partly answers this question about the physicians not understanding, the physicians not getting the science, and this explains the science in very, very easy to understand terms, but taking it one step further about how the brain is so involved with all of this. My colleague, Mike Schwartz, has done two different studies, one with a type 2 model of diabetic mouse. They were obese, and he injected the brain with something called fibroblast growth factor, FGF. And what he did by putting this chemical in the brain, and we're not exactly sure how it worked, but he cured the mice of their type 2 diabetes because he did something to the brain that cured them. It's the brain. But as interesting as that is, it gets more interesting. There's a type 1 model of mouse, and instead of giving FGF, he gave a hormone discovered 30 years ago called leptin. And when leptin was given to these mice, they're type 1 mice, they don't make any insulin, the diabetes was cured. They had no insulin, they survived their entire life, they didn't have a pancreas, and they survived without insulin. And Mike and many of us feel that we need to see if this also works in human, that if we can do something to the brain that you don't need insulin to survive. And of all the many studies I'm involved with, that's the one I'm most excited about as a proof of concept. If we can put leptin into the brain, can we get people off of insulin? The brain is really powerful, and that 60 minutes goes into it very well.
Well, thank you. I think one of the first questions that came in, speaking of curing diabetes, was the status of stem cell transplants for diabetes. Anyone want to take that?
I would definitely defer to Earl on that.
Well, I was unfortunately or fortunately, I get a lot of those questions because about a year ago, I was quoted in the New York Times when that patient was presented who was off insulin. I think all of the stem cell research is exciting. I'm hoping to learn more about it this year, that we see more long-term follow-up data. But my overall general take on it is it's one thing not to take insulin and not to worry about getting too low, about getting too high, about how am I going to deal with exercise. It's getting off of insulin. No one would argue that is a tremendous, tremendous benefit. But what is the cost? And I'm not talking about the financial cost, which, by the way, is quite substantial. The cost is immunosuppression right now.
Wow.
And I take care of many immunosuppressed patients, all different kinds of immunosuppressed patients, but the ones who are the most concerning are the transplant patients. The 20-year kidney transplant, we're seeing 10-year heart transplant, we're seeing these long-term lung transplants and the liver transplants, and I see them all. And the problem with them is the extremely, extremely high risk of malignancy. And so the question is, even without all of the infectious complications we see, I mean, the last thing I want to have to deal with is an immunocompromised patient during another pandemic. I mean, that's bad enough, but it's the malignancy risk that is just so sky high in all of these patients. And if I have somebody who is at least doing well with their diabetes, do I want to put them on full immunosuppression so they don't have to take insulin? I can't go that way. Now, we used to do a lot of pancreas transplants for people who had hypoglycemia unawareness, but that was in the era before we had continuous glucose monitoring. And I'm sure we do them still. Not, from my knowledge, nobody from our clinic has had a pancreas transplant due to hypoglycemia unawareness. I don't know of it. We used to do a lot of these 20 years ago, but it's the immunosuppression that I can't buy into it until we get past that.
So I totally agree with Earl. I've never referred a patient for a pancreas transplant unless they need a concurrent kidney transplant, in which case I think if they're going to be on immunosuppressant anyway, that is a possibility. So I think that's one exception. But I also think the concept of what is being developed not only is taking stem cells, which we've previously not been able to use on a commercial quote basis, but also some of the techniques they're studying to prevent the need for immunosuppressants. So I'm still very excited about the science. We're definitely not there yet. And I agree with all of your comments about the malignancy potential. And I tell patients, you're trading one disease for another. What would you rather do, is take insulin or have, a cancer that is life-threatening? And most people understand that concept.
That's great. So let me just ask you another related question then. A question came in about insulin toxicity. And should that be something that we worry about in delaying the use of insulin?
I'm not exactly sure. There was a big concern. I'm going back to the late 80s and early 90s that insulin was atherogenic in of itself. And the concern was if you give insulin, you're going to have a higher risk of a heart attack, a higher risk of a stroke. And that has essentially been shown not to be true. We generally start insulin today when we don't have other choices. And we'll start them in young people, women of childbearing age in particular, where they really do need the insulin because these other drugs we can't use during pregnancy. But if I'm understanding right, when you say insulin toxicity, I think you're talking about the fact that the insulin, the concern was it was atherogenic, meaning it causes heart attacks and strokes. I will say that there is a difference between an association and a cause. And if you look at people with type 2 diabetes, as a rule of thumb, they have high insulin levels in their blood, and they have the high insulin levels because they're resistant to insulin. And those insulin levels are going to go higher when you inject insulin because you don't have anything else to give them for their diabetes. Although we have somewhere between 22 and 24% of Americans with type 2 diabetes in this country on insulin, that number actually is going down as we use more of these other drugs. But to your question, I don't think that toxicity to insulin is our big problem.
Yeah, I agree. So it's better to do something that helps a person lose weight. So a medication that is weight beneficial is going to give them better outcomes. But if you take a patient who has high blood sugar and you compare the person with high blood sugar without insulin injections versus those that have high blood sugar with insulin injections, there's no question. And studies, the old UK-PDS study showed that patients on insulin did better. So I think this concept of insulin toxicity is something that is an association due to the impact of insulin resistance, not to the impact of insulin itself.
You know, I'm just reminded, it's so gratifying to hear just how science is informing the changes that we're seeing in diabetic management from the basic pathophysiology to what's really happening at the bedside. And I think it's just a tribute to what we should be doing. So thank you for that. A couple questions came in about continuous glucose monitoring and whether or not those can be used for the diagnosis of diabetes. And wonder what your take on that might be.
The short answer is no. By the same way, you can't use a finger stick glucose to diagnose diabetes. It needs to be an approved A1C. The home A1C kits, by the way, can't be used for diagnosing diabetes either. It needs to come from a lab that is standardized. And most of the labs are. But you can't use CGM. Having said that, for somebody who has no known prediabetes or early type 2 diabetes, I think wearing a CGM is great. Like we said, it really informs the patient about how lifestyle modifications change things. But unfortunately, we're not at a point where we can use them to diagnose diabetes.
One of the questions came in about what do you tell people who get started on one of these new medications, either the SGLTs or the GLPs, in terms of what do you tell them in terms of patient education, what's appropriate, and then what kind of follow-up and testing monitoring do you do?
I can start unless Carol, you wanna go on that one. I'm more than happy to.
Yeah, no, I actually, for starting these agents in patients who are not on insulin, it is pretty easy. So this was a cardiologist asking this question, by the way. So think about your answer as it would relate to that. So the biggest issue with these agents is obviously things that they already know about: problems with dehydration, low blood pressure, and then the concern about with the SGLT2 inhibitors, genital mycotic infections with a GLP-1 receptor agonist, nausea and vomiting. So for the GLP-1 receptor agonist, because that's what he's going to be using most of the time, it's just advising patients to make sure they drink water, adjusting their diuretics so that they avoid hypoglycemia. And then for women, recommending good hygiene to make sure that they don't get a yeast infection, a vaginal yeast infection. And if they're on sulfonylurea, you need to lower or stop the dose. If they're on insulin, you need to lower or stop basal insulin. But I would say to the cardiologist, if they're on basal insulin or any insulin, they should probably talk with their primary about that. And then as far as the GLP-1s, it's start low, go slow. And I am a big one for taking something that I can titrate even by just a few clicks per, 2 or 3 weeks to try to minimize the impact of the GI. And again, we talk about importance of decreased serving sizes, making sure that they don't sit down to a gigantic meal because that's going to make them feel sick. And making sure that you use all the other healthcare and lifestyle things that we've talked about already.
Yeah, it was interesting. I had a conversation with a cardiologist as well, who's interested in starting an SGLT2 for the cardio data, which is very good. Unfortunately, this person's hemoglobin A1C was 11. So there's this sort of tension between this is probably not the best choice for this person right now because of the risk of dehydration and maybe some increased risk of DKA. What about a GLP-1 first? And maybe we can get that A1C down a little bit lower and then start the SGLT2 in terms of the order of that in this particular patient that we were.
That's excellent. That's an excellent recommendation. That's really good.
Yeah, and in fact, Anneke, I'm not sure how much more glycosuria you can have if you have an A1C of 11 anyway.
Agreed.
You're already peeing out sugar cubes. But I will say, if it's a cardiologist, I've seen this a handful of times in the last couple of years. These drugs have become very popular both in the cardiology and the nephrology, the kidney doctors world. And with good reason. The data is just, unambiguous. The problem that we've had, and maybe you don't have this in Spokane, but the problem that we've had is that we've had patients coming in, started by their cardiologists on the SGLT2 inhibitors, and there are good cardiac reasons to start it, but these are patients with type 1 diabetes.
Yes. Yes.
And we've seen this over and over and over. And I don't see this as much from the nephrologist, but I see this from the cardiologist. Now, I'm going to say that I do have a few patients on SGLT2 inhibitors with type 1 diabetes. I imagine, Carol, you do too, and they're used off-label. But as a rule of thumb, the reason why we don't use these drugs in type 1 diabetes is due to the very high risk of ketoacidosis. And the ketoacidosis can occur without the blood sugar being high. And so the patient has no clue why they're sick, why they're vomiting. Their blood sugar is 140. And then they go into the ER, and the ER doctor is scratching their head too, because they don't know about it. I think they know a little bit more about it now that we've had these drugs a few years, but I can't tell you how many times in the ER they missed the euglycemic DKA diagnosis. And so from my point of view, for anybody, whether it's primary care, cardiology, endocrinology, it doesn't matter. You need to make sure, what kind of diabetes does this patient have?
So that's very easy for the cardiologist. If they're on prandial insulin, they need to have some additional input from the treating physician or provider. And I think the other piece of advice that I give people to prevent this is if you can't eat, you can't drink, you don't take your medicine. So that helps those patients with type 2 diabetes avoid that unfortunate episode, rare, but that episode of DKA, of diabetic ketoacidosis.
Yeah, and one other point, anybody taking prandial insulin, including the type 2 patient, with the GLP-1, it's not only that you need to cut back on the insulin as you increase the dose, which you do, the blood sugars come down, but remember the slide, I said the food stays in the stomach longer. It takes longer for that food to get out. So if you give your dose of Humalog or Novolog, or even one of the faster acting mealtime insulins, and you give it 15 minutes before eating, and it's somebody who has 2 milligrams of Ozempic on board, that food is going to sit there for hours while the insulin is hitting the patient. And that's another place where we have to be so careful with hypoglycemia.
Do you counsel your patients about an increased cancer risk with the GLPs?
No.
It's absolutely not a non-issue, unless you are a professor at USC who still thinks it's true, but it's been shown not to be.
No, I actually tell patients it's in the package insert, but we now have studies that probably include 60,000+ people over several years and have failed to show an association between those agents and cancer.
Question, there's an organization here in town about, it's called STIX, and the question came in is, do you see better results in patients who connect with a type 1 or type 2 diabetes community? Any data on that?
I would say especially my young adults, yes. So especially people who are transitioning from a pediatric endocrinology clinic to the adult world, right? You're already struggling to become an adult, and we just plopped on this very complex chronic disease that you get to manage more independently now. So having that safety net be bigger, especially people your own age, I have seen people be much more successful in managing that disease and troubleshooting it as a community. It was really interesting actually during COVID, where a lot of our in-person support groups and stuff went away. I felt like the peer support online got a lot better, like through Diabetes Sisters or the type 1 support groups online, a little bit more active. And so being able to utilize that virtual world with some good success during that time too, kind of another unforeseen
Side benefit.
something.
So yeah, my patients who connect, even if it is online, much more so in at least in our community, we don't have as much, direct kind of support. But the people who connect online, they have a lot more information and they ask a lot better questions. And I think they push me to do a better job because they make me think of things that I might not necessarily consider. And they come up with some crazy ideas sometimes too, and we have to deal with those as well.
Yeah, it's same on this side of the state. I will point out to Anneke's point, about 5-6 years ago, maybe 7 years ago, I lose track of time, we started an adolescent young adult clinic for these transitioning kids in a collaboration with Seattle Children's Hospital and our diabetes clinic and our Diabetes Institute. And we've presented data, I'm not sure if it's been published yet, showing this dramatic reduction of A1C. We're going to be showing data at ADA, looking at diabetes distress and other markers about what we can do with these kids in this and young adults in this different type of environment that focuses on this transition. So it's all very positive.
So Dr. Hirsch, I'm going to go back to a comment you made earlier about in type 2 diabetes, how we don't understand or we get a handle on how the islet cells make less and less insulin as we go along. So 2 questions regarding that. Number one, with the new medications, do we have evidence of their durable effect over a long period of time? And do we expect to see the same sort of attrition in insulin secretion? And then along with that, some of the weight loss that goes along with that, there's some questions have been submitted about whether or not that weight loss is durable after the medication is discontinued. So 2 different questions, but related to the medications.
Well, let's first talk about the beta cell failure. The first thing to understand is that it's hard to do studies with this because some people don't lose much beta cell function over time. When we talk about clinical trials, we talk about averages. And on average, when you're dealing with a sulfonylurea, it will only work, depending on the study, it will work well for 3 to 5 years. Having said that, I have patients who have been on sulfonylureas and having a great effect for it for 15, 20 years. And so to really, so any individual may be very different than the average. That's point number one. What we used to tell patients when all we had were sulfonylureas and insulin, and this is even before we had metformin, we would tell type 2 patients, unfortunately, your sulfonylurea is going to lose its efficacy and you will need insulin. That's what we were taught to do because we didn't have any other options. And I from what I can see so far, that is not at all the truth anymore. First of all, one of our colleagues in Texas published a paper a few years ago showing that the combination of metformin, a drug I didn't talk about called pioglitazone, on top of, I believe it was liraglutide, Victoza. I think that was the GLP-1 he used, or maybe it was Bydureon. I can't remember which.
Byada.
That it was Byada.
Yeah.
Yeah, he showed that was more durable and created better beta cell function over, it was either 3 years or 5 years. It's been so long since I've seen the study.
I think it was both.
And so there are ways to minimize the fact that the insulin secretion does go down over time. But I think more importantly that while we can do that a little bit, we can't stop it in its tracks. Nobody can do that. And related to your second question, at least all the data we have now with the GLP-1s and weight loss is I can make the following conclusions. What we understand now is the weight loss is durable, but what we also understand is as soon as that drug is stopped, the brain is switched back and the weight's going to come back through no fault of the patient. It's the brain, it's the biology, it's the science, it's the medicine. And that's what patients and frankly my colleagues need to understand. And I just feel that this is a new beginning of the study of obesity and understanding it. And my hope is that we understand it much better with even more specific drugs for the next generation of physicians. I don't know, Carol, do you have anything to add to that?
I would just say that the supply and demand, it's really easy for people to understand that their blood sugar is related to what their supply of insulin is versus their demand, and significant reductions in food intake and significant reductions in weight make that balance in favor of lower blood sugars. And so it's not proven, and I'm going to say that on the front end, but starting agents that help with weight loss earlier in the course of the disease. And if the patient is fortunate enough to have the weight loss and sustain it, can delay the need for more advanced therapies later on.
Yeah, and I do think it's also helpful to think about obesity treatment like chronic disease management, right? That some of the agents that we see are going to be maintenance medications for some people because of the desire for the durability of therapy. So I think that's an important, as I'm counseling patients on the use of GLP-1s or Mounjaro, the GLPs, GIPs, this is probably going to be a medication that you are going to take for a very long time. It's not something that you're going to drop 30 pounds and then we're going to take it away and you will be able to live your life. Or the Hollywood, you lose 10 pounds and then you come off of it and are able to maintain that. And I think that's an important piece of education that goes into prescribing those very highly effective weight loss medications.
I have one final point I want to make, and that is we're talking about these GLP-1s and the GLP-1 GIP, the Mounjaro, and the amazing things we see. But what we also see is 20% of people on these drugs do not lose weight. They still get a glycemic benefit.
That's not true of Mounjaro. That's not true.
Not true of Mounjaro.
It's not true. It's only about 5% on Mounjaro. It is true of the GI.
But even that 5%, it just shows how we don't understand everything going on in the brain. We're talking about it as a switch, and we're not giving it enough credit for its complexity. And, you know, the point is there is a pharmacogenetic effect. Think about that word, pharmacogenetic. There's something in our genes where some people are going to have a tremendous effect and some people will have little effect as far as we're just talking about the weight now, not about the glucose, cardiovascular, and renal. I have a woman on Trulicity. She lost 103 pounds. Why is that? I don't know.
You know, one of the things that I don't think I've heard said yet tonight is the fact that you get, you know, I'm looking to you to verify this or correct me, but relatively small decreases in weight have greater metabolic effects. And, you know, if you lose 5% of your body weight, you don't have to get down to ideal body weight in order to get to reap some of the benefits that we're talking about. Any thoughts on that?
So important, but it depends on what your goals are. You know, if your goals are to, improve your diabetes control, 5% of your body weight is important. But if you have fatty liver and, see inflammation in your liver, you need 10%. If you're trying to reduce your risk for cardiovascular disease, you need 10%. But I always go on that first 5%. You get the majority of your health benefit for the diabetes control within that first 5%.
So Carol, you just walked into that trap because that was my next question, was the one that we haven't talked about yet that is also increasing is liver disease along with diabetes. And I know that's an entire talk on into itself.
So much my interest right now. I'm teaching every resident that comes through my service. You need to do the FIB-4 score on all of your patients with diabetes. If you have type 2 diabetes and or obese type 1 diabetes, your risk of having fat in your liver is greater than 70%. And that increases risk for cirrhosis and for liver cancer. So that we need to be monitoring these patients. They are our patients. They're in our clinic. If we don't do it, no one will. And we will not be able to identify them and apply these evidence-based therapies, lifestyle interventions, and monitoring to prevent some of the serious outcomes.
It's the number one cause for liver transplant in the United States now.
Yeah.
Yeah, that's a shocking number. That's going to be, that the number one cause is through obesity and diabetes mellitus. So really shocking. Any final comments before I'll ask Anneke for some final comments, then Carol, and we'll finish up with Dr. Hirsch. I
have a question
for
my fellow panelists. I'm curious about your use of GLP-1s in LADA individuals, people who still have a C-peptide, but we got autoantibodies. Maybe their C-peptide is like 0.5. Thoughts, experience?
So I put all my LADAs, diagnosis and EPIC as LADA, treated as type 2 until I can't treat them that way anymore. So that way I can use the GLP-1s. Okay. And extraordinarily helpful, obviously better with higher A1Cs, but until they need an insulin pump, and then I switch their diagnosis to, latent autoimmune diabetes treated as type 1.
So when we did the adjunct study, which was Victoza in type 1 diabetes, what we found was that those people who were still making C-peptide and were LADA patients, they did significantly better. The C-peptide negative patients, not so much at all. And the little tidbit, Anneke, I will tease you with is there will be a study published later this year about newly diagnosed adults with type 1 diabetes, and at their diagnosis, they're put on a GLP-1, and what happens to them over the next 1 to 2 years. And I think there'll be a lot of excitement when this paper comes out.
Oh, thank you for that.
All right. Carol, any closing comments?
I just want to echo something that Earl said earlier, I have been in diabetes just a bit longer than he has, at least professionally. And I have to say that the difference in what I see coming through the clinic in terms of, complications and, just the ability for us to achieve what we consider good control is dramatically changed over the last 30 plus years. And it's an exciting time. I love to talk to new patients with diabetes. I don't get to see them very often, but I love to talk to them about how we can change what their perception and what their natural history is if they work in partnership with us to get their best possible control.
So I have two comments. One is because I've been here as long as I have at the University of Washington, and I saw most of the new patients in the 1990s. Our colleague, Dr. Trentz, didn't come until 2001. So my first 11 years here, it was mostly just me, and most of those patients I still see. And the reason why that's so interesting is that about 35% of my patients, mostly type 1, but also type 2 diabetes, are a population of patients we didn't see before, and that is geriatric type 1 diabetes.
Mm-hmm.
It's also a population we don't know much about because it's a population 30 years ago didn't really exist. And now it really exists. It's a growing population. And frankly, it's hitting Medicare like a tsunami, which is a good thing, actually. It means that our treatments have been successful. So that's something I'm very encouraged about. The other point, which we did not talk about at all tonight, is a lot of the work we are doing for people with diabetes when they are admitted to the hospital. And my colleagues and I from around the world, what we have shown, especially if you are admitted to the intensive care unit, we have shown that if you know your A1C, whether you have diabetes or not, whether you have known diabetes or not, since so many people in the community don't know they have diabetes, what we showed is that if you have a high A1C, meaning above the 8%, and we treat you down to the guidelines of where we think your blood sugars should be, if you have a high A1C and we treat you to those guidelines, you have a very bad outcome. Your risk of mortality is 5-fold. And on the other hand, if you have a well-controlled diabetes, we actually do want to treat you to those guidelines unless you come into the hospital and you're on insulin. And for reasons we have no idea why, if you have well-controlled diabetes and you're on insulin, our data suggests you want the blood sugars to be high. Now, we don't understand any of this. We actually had an article go online today about the mechanism of this that Mike Schwartz and Mike Brownlee helped write. I was a co-author on this. But I am so excited about what we're going to see over the next few years for people with and without diabetes about what the glucose target should be in the hospital. And it's my belief the only way we're going to both do the studies and get to these outcomes is having CGM be good enough to work in the hospital. And once we have CGM in the hospital and we have these studies to show what the targets should be, because right now we are doing this by a consensus, meaning we don't really know. We don't have the data. So I'm excited about that.
Well, I think that's the message I think I want to convey as we close, is just the optimism that all three of you have expressed about this very difficult disease. I also want to acknowledge that there were lots of questions submitted in the Q&A that we were unable to get to. We will do our best to try and answer those and have them with the recording that goes out. Everybody who's registered for the webinar will get a link to the recording, so appreciate that and look for that in the future. I want to thank our sponsors, Providence, MultiCare, Spokane Regional Health District, the County Medical Society, UW Population Health Initiative, as well as Inland Northwest Behavioral Health. I also just want to thank all of our attendees. You guys stuck with it. It was just great talk. You gave up part of your evening to learn, which is always a great thing. And want to thank Dr. Hirsch, Dr. Wysham, and Anneke. This was just really a great discussion. So thank you very much for giving up part of your evening with us tonight.
My pleasure.
Thank you.
All right. Thank you. Good night.